This conference will now be recorded.
Let's see, it's trying to share my screen.
Here it is.
All right, so you see,
Database.
okay, so this is a fun case. So if you remember last week, Maya showed a case of thyroiditis from a checkpoint inhibitor. And so go figure the next day, after learning something about it, I noticed, so this is a patient, let me show the scan I came across. So you'll notice this patient, this was, honestly, I don't remember what their primary was, but you'll notice the thyroid gland is very hard to see. It's very small. And I usually, it's just one of the areas I'm always looking at the thyroid gland. And I happened to notice that on the previous one, this patient had a nice healthy looking thyroid gland, and you can see there's iodine in it. It's bright. Look on the current one, it's hard to see. There's no iodine in it. And I found a PET CT done between the two that shows FDG uptake in the thyroid. So this is after treatment between the two scans. And so looked around a little bit, and sure enough, this patient had thyroiditis at this time from their, this was pembrolizumab, and is now, and it caused enough damage the patient is requiring levothyroxine therapy. But I would have never even made the connection unless I'd seen Maya's case from the day before. So this is a case of pembrolizumab-induced thyroiditis with a burned out thyroid afterwards. So it is a known entity. We just probably don't notice it much because it's more probably symptomatic and biochemical, but this one was enough that it caused diffuse gland inflammation and then atrophy.
What's the prognosis for that if left untreated? Do they recover? Does the thyroid come back?
I don't know. I don't know at all. I don't, it's not, yeah, I didn't look into that, but I mean, this patient's requiring thyroid replacement hormone. So I'm presuming it's, I don't know if it's reversible or not, but I've been looking for it now. So we'll see
Her
when I come
her
across another.
her case was also related to pembrolizumab.
Right. And I think in her case, the thyroid got big.
That's right. Yeah.
Right. And in my case, the thyroid, so I saw it after the fact. In this case, it was normal size, but it was hypermetabolic.
Right.
Okay, so that was the first one. You're gonna like this case because this is just one I haven't seen one of these in a while, and I always wondered why. Because used to, when I was a resident, you would always show them in case conference. So
Right.
here's the frontal radiograph, and you can see there's a extra bump here in the mediastinum, and both of them seem to displace the trachea to the right, patient's right. Here is the lateral, and you can see there's this little extra mass back here behind the trachea, and there's sort of an acute angle, and then we see the descending aorta. And so this patient was being worked up for aortic stenosis, and low has a normal thyroid there, but you can see right here, and I'll make a sagittal, we have an abnormal configuration of the aorta. And then if we come down here, we can see that there is a thickened calcified valve. And I don't have it in valve planes, but it is a bicuspid valve. So if we go to the sagittal, you can see here is a kink in the aorta. There's a little atherosclerosis right there, but otherwise it's in normal caliber, maybe a little bit big here. I'm thickening it up with a MIP. So this is a nice example of pseudo-coarctation of the aorta, which is the two definitions I found is one where you get this kink with a gradient less than 10 millimeters, or it's another separate congenital lesion where it's thought to be, you get this high riding arch thought to maybe develop from a different primitive arch, and so as the patient grows, the ligamentum is in the normal place, acts as an anchor, and so it causes this kink. But like a coarctation, half of these patients have a bicuspid aortic valve, and this one had all of the above. So it's rare I see these anymore. I don't know. Maybe you just kept showing us the same case, but it had such a classic radiograph. It was kind of fun.
So the actual arch is that upper portion, and
Right.
that's too high. So the post kink is the normal height of the arch. And so
Right. It
this
should be on top of it.
right. That's what makes me think that this comes from a higher,
Yeah.
primitive arch. And
Yeah,
I
normally
had
it's the left four, so I wonder if
recommended,
it's the third.
I think so. That's my guess. But you and I support each other in that. It must be true. So the I like your comment about the relationship to the ligamentum arteriosum, which is very clearly visible in your case here. So I hadn't it
Hmm.
hadn't occurred to me that that was right at the position of the
Yep, you can see it right
of
here.
the deformity. Yeah, that's perfect.
It
So
acts
this
as
is
like a
kind of
test.
the three sign on lateral view. So if you see a three sign, chances are it's not really a cohort; it's a pseudo-cohort.
Yeah, also the patient's in her 70s.
Right.
But yeah, the bicuspid aortic valve is the important thing to remember. Okay, this is a cool case. This was an incidental finding. Well, I was unaware of the history at the time, but confirmed it later. So this is a 30-something-year-old woman who was in a motorcycle crash, and as part of her trauma work, I've got a CT. I'm not sure what they did. It was from the outside. They did a non-contrast, which is fine. Most of her injuries were lower extremity, but you'll notice her trachea and main and even lobar bronchi are calcified, but also the caliber is quite small. And so we see calcium in older patients, but not 37-year-olds. One thing you think about is warfarin can cause calcification, but this is confined only to the cartilaginous portions. And on the lung windows, you'll see just how small her trachea is. So this is pretty classic. So this is like a great one for an exam or something because there's really not a differential diagnosis. This is typical of relapsing polychondritis. It spares the posterior membrane, it's diffuse, and only involves the cartilaginous portions of the central airways. And lo and behold, I confirmed, because our traumas come in without confirmed names, so they're unidentified. But once she got admitted and all that, and they merged all her records, I confirmed she does carry a diagnosis of relapsing polychondritis, for which she's on methotrexate and has been doing fairly well from it. So she doesn't have any high-grade stenoses. But I remembered back to some other cases, they can get some other findings. And so I found this head CT that was done at the same time. And if you look at her pinna here on the right, you can see the cartilage is calcified on both sides. Almost looks like it's ossified. And then her nose, maybe, it's hard to say, there may be a little bit of calcification in there. So I've seen a couple cases with ear cartilage, but it often presents with ear swelling, redness. They can get joint pains and stuff like that. So relapsing polychondritis with classic CT findings in the pinnae and in the trachea.
Excellent.
Yes, rare disease, but it's pretty classic. I'm going to save this one for last because it's a mess. Um, this is an interesting case. So this is a 69-year-old person who presented with urinary retention and back pain. So they got this abdominal CT, and there's a lot of motion artifact, but you can bear with me through that. And at this point, they put a catheter in the bladder, but you'll notice that the prostate gland is enlarged and has all this like low attenuation in it. So it looks like a bunch of prostatic abscesses. It's enlarged as well, so like a prostatitis. And then it's subtle, but there are some striated nephrograms. You can see a couple little stripes going through, just very subtle, going through the kidney. So probably a secondary urinary tract infection. And if we get to the very top of the scan, you'll notice right here, the bone doesn't look so hot. I'm going to go to a different window. You can see there's some uh, digestion of bone and all this soft tissue around it. So we have a chest CT to go along with it, and the patient has pleural effusion. You'll notice the right heart looks a little on the big side. There's quite a bit of pulmonary embolism, which I don't think is related directly. And if we look at that spinal stuff, here you can see it involves at least two bones, multiple disc spaces, but I got the right windows. There we go. You'll notice the disc spaces are relatively preserved. And if we go to the soft tissues, there is some soft tissue around it. Let me go back to axial for that, so it's a little bit better. But there is this kind of paraspinal abscess here contains soft tissue. And then the thing that really unites the diagnosis is looking at the lungs. And again, there's a ton of motion artifact, but if you look very carefully, you'll start seeing there's a ton of tiny nodules in a random distribution. And a couple slices, they stand out better. Then you get a lot of blurring. But right here, for example, you can see there's just tons of tiny nodules. So this is a miliary pattern of random nodules, a little bit more confluent stuff here. And so if we want to tie this all together, we've got prostatitis, osteomyelitis discitis, miliary nodules in the lungs, and probably a secondary UTI. So this is all disseminated tuberculosis, miliary TB, and of course can cause abscesses in various places. So as the so-called Pott's disease, the spinal portion. And that's very typical to sort of preserve the disc space, involve multiple levels, have a paraspinal abscess, and then it can affect the prostate gland. It can go to kidneys. I don't think it's in the kidneys. There's not like a lot of TB-looking abscesses in there. I suspect it's probably just an obstructive UTI. But this was a kind of a fun case where you can sort of tie it all together. I can't explain the pulmonary embolism. It's not typical of TB that I'm aware of, but just another finding.
Wow.
All right, and this last case is a real mess too. So this is a 63-year-old female who had, I got to get these person in the right order here, who was transferred to us from an outside hospital. She had had stent grafts placed in her descending aorta, and then had 2 revisions for endo leaks, and then developed a big complication. So this was, I believe, one of her outside scans. And so she was transferred to us for this big pleural effusion and this infection here. She's got all this gas sitting around her graft. And they were concerned that it had indeed eroded into her esophagus, and she developed a fistula, secondary graft infection. And so after when she got here, we did so this contrast is from the outside. This was on their study, but we did an esophagram. So this, I can't remember where we are in the scan. We had so many. Let me see if I can find the right sequence here. That's the outside. This is us here. Yes. So this is our post swallow, and you can see so what we would do in a case like this is we would, if they've had instrumentation at all, we do a non-contrast just before they drink, and then we have them drink 1 swallow, and then we have them hold a second amount in their mouth that they swallow right before the scan. And we've recently added a thickening agent into our contrast based on some publications, and so we've gotten some nicer looking boluses. But you can see there's all this extraluminal contrast here wrapping around the stent graft. And actually, if you look here, this bone doesn't look so happy either. So there is a component of osteomyelitis involving the spinal vertebra here. And then they did we did end up doing an aortogram too the next day. And I think this is on the delays. You can see it to advantage. You can see that this is actually the excluded aneurysm sac here, because it was hard to tell that on the esophagram. All we could tell is the contrast was not, there was no air in the graft or right along it. But here it's clearly in the sac. And if we follow the esophagus down, you can see the tube in it. So the leak is somewhere down here, hard to see exactly where, but it's all infected there. And then I think we had a more recent one. Let me see if I can find it. Let's see, this is a better. Yeah, here we can see more contrast in here. So a persistent leak around there, but you can see on the aortic side here that there's no leak of the IV contrast out. I thought I had a more recent chest CT, but I don't seem to have it. But anyway, this is an aortoesophageal fistula, which are usually pretty bad. So they ended up putting a stent across the leak in the esophagus, and there's a little tissue, so it's not true stent on stent, but it's close. And then they've just draining this collection out here that came in there, and I think they're hoping to cool this off. I don't know what they're going to do long term, but very complicated case. It's more common with surgical repairs with grafts and stuff, but presumably with the aneurysm there was some inflammation enough, and with all the instrumentation and endo leaks, maybe contributed to a breakdown in the esophagus, maybe some ischemia that led to it as well.
Wow.
So,
Jeff,
yeah.
there was on on the early CT, I think there was contrast getting into the right pleural space. Am I right about
Yeah,
that?
so she came with that before we even had her drink. So at one point there was a fistula with the pleural space, and they
Hmm.
drained that. That seems to have closed because when we gave oral contrast, it did not increase, and on
Got it.
subsequent imaging it was gone. But yes, you know, I was worried about that. But that's having that non-contrast pre-drink, I guess, beforehand helped us sort that out. So yeah, these are tough, and they surgery wasn't thrilled about what they could do with it, because you got an infected graft or presumably infected graft, and the esophagus doesn't. I mean, sort of covering up, giving them a lot of antibiotics and draining what you can. So I think the hope is that they clear out the infection best as possible. I don't know what the long term solution is going to be for this esophagus, but they'll figure it
You'd,
out.
you'd almost need a mediastinal transplant, really.
Yeah, I mean, you almost need like a conduit away from the mediastinum, like
Yeah.
a colonic interposition or something, but not something to be undertaken lightly. So,
I remember the thoracic surgeon at Duke when I was there in the 80s who handled both the esophageal cancer cases and the aortic dissection cases, and so he had the two riskiest organs in the thorax to deal with, and the esophageal anastomoses at that in that era were always breaking down and leaking and things like that. So this
hmm
person combines both of those very difficult organs, the aorta and the esophagus. This is really,
right.
a scary amount of potential complication.
Yeah. I mean, the aorta is pretty tough, but the esophagus not so much. So, all right. Well, that is what I have. So I guess unless anybody joined in the meantime, let me see. I don't think so. We'll just end it on a short note today. But thanks for
So
coming,
Jeff,
David. And
what about next week? It's Rentgen Ray week. Will you have a conference? Do you think?
I will be around, so I'm planning on it. I don't know if Travis will be there or not, but he hasn't been on in a couple weeks, and I haven't. Seth's probably very busy, so and
Okay. Okay.
I'll plan on being around. So
I'll have some cases too. All right. Thank
okay,
you.
talk to you next week.
Bye bye.
Bye.